With COVID-19, we're starting to see very early and very encouraging reports from China about the use of convalescent plasma. I think that the most influential one was published just last week, or maybe 2 weeks ago in JAMA, and it was a case report of 5 critically ill patients in China, all of whom had ARDS and viremia and were on ventilators. So these were very sick people, and they were transfused with high titer convalescent plasma from 5 different donors. So they did not all get convalescent plasma from the same donor, even though there were 5 of them. And in addition to convalescent plasma, they were also treated with what seems to be the standard of care there, which included steroids and antiviral treatment. And some of those antiviral treatments aren't familiar to practice to people in the United States, and so it's hard to know exactly what that means. But what you can see is that all 5 of these people had significant complications before they received plasma, at least ARDS, and several of them also had pneumonia, and one of them had fungal pneumonia and heart damage. And what happened when they gave the plasma is that the patients, some of the patients immediately had a reduction in their temperatures, although not all of them. I think patient 2 is very interesting, went from having a 39-degree body temperature to 36.8, which was encouraging, but not all patients saw this. But their SOFA score, which is a measurement that of 6 different organ systems, you get a score of 1 through 4 of each one of the organ systems, and the higher your overall score, basically the worse a patient's prognosis is. So when the SOFA score goes down, it means that the patients are, on a global assessment, doing better. All of them had SOFA scores that decreased after getting the plasma, although it took quite some time. They also had neutralization of the virus, and 3 of the 5 patients were actually extubated. And so it's very encouraging to think, even though it's only 5 patients, these were 5 patients who were sick enough that it's very tempting to believe that had they not gotten this convalescent plasma treatment, that they might not have done as well as they did. But it's hard to say. There's also another paper of 10 patients with severe COVID-19 who received 200 milliliters of convalescent plasma, and this was also from China and had 10 patients instead of 5. But similar to the report from JAMA, there was no control group, and different from the report in JAMA, only 7 of the 10 patients had viremia at the time that they got convalescent plasma. So it's a little bit unclear exactly. One would think that you would give the convalescent plasma to people with active disease and viremia, but 3 of the patients in this report didn't get it, which is okay. It's just such a small number of cases, it's hard to draw conclusions. And what this report identified is that the viremia resolved in all the patients who had viremia to begin with, and also there was a trend towards a reduction in inflammation, a recovery of lymphocyte count, which we talked about was that lymphopenia was associated with severe disease, and also an improvement in oxygen saturation. And so where we are today is that we're in a situation where we're fighting an extremely dangerous, horrible disease. We don't have a definitive therapy that's available yet, although I think that every researcher, every government, every regulatory authority is literally doing everything they possibly can to promote the development of those. But the question is, what are we going to do for people right now who are sick, who already have COVID, and need to receive some kind of treatment? And in the United States, there are 3 available treatment pathways that have been developed extremely rapidly to make it available to patients, convalescent plasma, hoping that it will lead to positive effects for people who are sick. The first thing that happened was that on March 24th, I believe, the FDA released a mechanism for emergency access to convalescent plasma. I put the link there, but basically even if you are taking care of somebody in the United States, even if you don't have a clinical trial at your institution, If you identify somebody who you think could benefit from convalescent plasma, and the patient meets the criteria that are outlined in the FDA documents here, which basically requires the patient to be quite sick, you can't give convalescent plasma in a prophylactic way through this pathway, then you can fill out a form, or if you don't have time to do that, call the FDA, and they will actually evaluate the case and consider giving you an emergency IND that you can use to give convalescent plasma to people. In addition to that, the Mayo Clinic has taken the lead on creating an IND for an expanded access program for patients who have severe or life-threatening disease. And this has been, I believe, a joint effort led by the Mayo Clinic, but with heavy involvement from United States regulators, the Food and Drug Administration, and BARDA, I believe, to fund this and to try to make sure that patients who are sick have a chance to get convalescent plasma. And the third pathway that's either available or soon becoming available are clinical trials. You know, as mentioned previously, convalescent plasma is an old therapy, and there are success stories, but it's also possible that there's equipoise about whether convalescent plasma helps or not. And so, in addition to making sure that people who are sick get convalescent plasma if it is felt by their treatment team that they would benefit from it, it's also important to study the utility of convalescent plasma. And so there's multi-institutional leadership of an increasing number of clinical trials, including some of my colleagues at Johns Hopkins. The Mayo Clinic is involved in these. WashU in St. Louis, Washington University in St. Louis is involved in these. And literally dozens of other medical centers are all working together, I think, in an unprecedented way to try to put together protocols and trials. And if you're interested in clinical trials, most of the protocols can be downloaded at this website, ccpp19.org. And I'm aware at the moment of 5 different trials. One's a prophylactic convalescent plasma trial for patients who are at risk of being exposed or who have been exposed. Another is a therapeutic convalescent plasma for patients who aren't very sick but have already been infected. There's also a single-arm study of convalescent plasma for patients with severe disease, although there's significant overlap here with the expanded access trial, and I'm not entirely sure whether people are going to go and use the expanded access or whether they're going to use this single-arm study as available through a trial. That protocol you can download for sure at the website. And there's also trials looking for patients early in infection, as well as an emerging trial that I think is going to try to assess pediatric disease. Fortunately, not a lot of children who have gotten sick compared to adults, but some children have, and it's important that we have a pathway to not only treat but also study the effect of convalescent plasma in pediatric patients. So thank you very much for listening. At this point, I will give the screen back to Axel.
Thank you very much, Dr. Gary, for the information, for this medical background information. This was very helpful to get a better understanding of this novel disease we are dealing with. Our next speaker is Dr. McCullough. Before we go there, I would just like to remind everybody, if you have a question you would like to ask, please use the toolbar on your screen, the Q&A toolbar, and enter your questions there. We will get to them after all 4 speakers have finished their remarks. So as I said, now we're moving on to Dr. McCullough. He will share with us how convalescent plasma has been used in the past for the treatment of infectious diseases, and we will discuss considerations for a successful convalescent program. Dr. McCullough, thank you.
Thank you, Axel. Can you go to the next slide, please? And this is a brief list of my disclosures, so let's move right on to, I'm going to back up a little bit here and become more general for the first few slides before becoming specific again. As Dr. Gary has mentioned, the concept of passive immunity is not new at all. And there's quite a list shown here of different situations in which the use of convalescent plasma has occurred. You see, it's a rather impressive list, and for some of these, specific products have been developed. Next slide, please. This illustrates the specific immune globulins that have been approved by the United States FDA. And again, you see it's a nice variety: rabies, hepatitis, pertussis, tetanus, vaccinia, and so on. So that it is clear that there has been a pretty good experience with this over the years. I mentioned CMV immune globulin at the bottom. This is not FDA approved. It was made for many years at the University of Minnesota. Next slide, please. Dr. Gary also mentioned that ideally, while current discussion is about convalescent plasma, ideally an immune globulin preparation would be very preferable. The first two websites here show that two companies have specifically announced in news releases that they are pursuing the development of a high titer immune globulin treatment. This is Takeda and Grifols. The advantages, of course, of hyperimmune globulin are that it's a ready-to-use drug. It has a long shelf life and can be easily available to begin treatment. Also, it is standardized, and so that provides a consistent standard approach to therapy, as opposed to the use of plasma, which will have varying titers. The disadvantage, of course, is high titer immune globulin isn't available now. This would require regulatory changes because it usually takes 12 to 18 months to manufacture a batch or a lot of immune globulin from the starting plasma. Apparently, it is possible to shorten this time to maybe about 6 months if there's adjustment in the plasma fractionation process and also agreement from the regulatory agencies. But another thing that has to be considered in the development of high titer immune globulin is the size of the batch. Ordinarily, the way these companies process plasma, a batch might be 50,000 liters, which means it's plasma from as many as 10,000 donors. So it's unlikely that in the short term, that much plasma could be obtained in order to begin to make a batch. So I'm told that these companies can make smaller batches, but again, this involves them altering their manufacturing processes in ways that they've not done and are not particularly familiar with. And it also involves agreement from the regulatory agencies of whether they can pursue this. Next slide. This illustrates, this is a brief news release, and it may be a little hard for you to read the small print here. The message in all this is that just about every plasma fractionation company has indicated that they are going to begin to develop these products. In the small print down there, Biotest, Octapharma, CSL Behring, Takeda, and others. So, clearly this is a very high priority for these plasma manufacturing companies. And there's a lot of good people. These people really know what they're doing. And I have no doubt that they will find a way to adjust their processes so that they can produce this material as reasonably quickly as possible. So that I think we can expect that there will be a hyperimmune globulin available for the COVID-19 treatment. How soon, it's a little difficult to say. I'm not an expert in this area, but I would guess that we're still talking about something that's probably a year away, maybe in the same kind of time frame as a vaccine that Dr. Gary just mentioned. Next slide, please. Let's talk a little bit more about the use of convalescent plasma in other diseases. Dr. Gary has mentioned a couple of them, which I'm going to say some more about in a minute. But interestingly enough, the idea of convalescent plasma is more than 100 years old. It was tried during the Spanish influenza pandemic in the early part of the 1900s. That was not plasma, that was whole blood. They didn't have the process to separate the plasma at that time. And while there aren't any reports that I found that have a lot of good data, the verbal interpretation of all this is the recipients of the blood transfusions were thought to recover faster. So this is not an old concept, as we've said many times already. The H1N1 influenza epidemic of about 10 years ago. I'm going to show you a couple slides in a minute about the use of convalescent plasma in that situation. Zaire virus is one of the hemorrhagic viruses in Africa, similar to Ebola. Ebola monoclonal antibody has been used in MAC monkeys to demonstrate effectiveness in that hemorrhagic virus. And Argentine hemorrhagic fever, another hemorrhagic virus. Actually, the use of convalescent plasma is part of the standard of care in managing that disease. Next slide, please. So Dr. Gary's already mentioned a bit about convalescent plasma in SARS, a severe acute respiratory syndrome. The particular reason to be interested in this, as you know, is in the same virus family as the current virus, which is also called SARS-CoV. There have been a few small studies. The data here is from 80 patients who were unresponsive to antiviral treatment during SARS. There was severe disease progression. These patients were treated with either 160 to 640 mils of plasma over a period of 7 to 30 days. So they got quite a variety of doses of plasma over quite a long period of time. In summary, the observation was that the earlier the treatment, the better outcome. And that was illustrated by a 6% fatality rate in those who received early treatment compared to a 22% fatality rate in those who received treatment later. Dr. Gary's already mentioned the two healthcare workers here. I think he had a third one, which I may have missed. These are individuals who received 500 mils of plasma each over about 24 hours. Within 24 hours of the transfusion, the virus was undetectable and the patients recovered. So who knows what to make? This is two patients. But the virus became undetectable and they recovered. So a meta-analysis of the experience with convalescent plasma during SARS indicated that it appeared there was about a 75% reduction in the odds of mortality in patients who received the convalescent plasma. But I want to emphasize that for the most part, these are small studies. They're not particularly well controlled, if at all. And so we have to hesitate a little bit on what we interpret from this. Next, please. Now, a little bit more about convalescent plasma during the H1N1 influenza epidemic. And I have the huge study here of two patients. The first patient you see had multi-organ failure, received 5 infusions of 100 mils of plasma at 5 to 10 hours intervals. The virus became undetectable. The patient fully recovered. That's a wonderful outcome for that patient. It's a little hard to know what to make of that. Second patient had 3 infusions of a total of 600 milliliters of plasma. And the viral load in that patient decreased by a factor of 10, from 10 to the 5th down to 10 to the 4th, 8 hours after the last infusion. The third patient was on a ventilator, got 1,200 mils of plasma, 6 transfusions at 200 mils each. Patient improved and was discharged. So this is, it's wonderful to see this kind of information. Unfortunately, it's not particularly highly structured, and so it's a little difficult to know what to make of it. It's encouraging, and it's one of the things that leads to the current interest in convalescent plasma. Next slide, please. I'm going to turn now to a little bit more about Ebola. During the Ebola epidemic of 10 or 12 years ago, the World Health Organization developed several position papers. And this is some points from one of the first. They indicated that in Ebola, nucleic acids are not usually demonstrable by 90 days after the onset of infection, but that high titers of antibody remain for more than a decade. Thus, most recovered patients can be a safe source of plasma for transfusion or IG production, according to the World Health Organization. So where feasible, they also mentioned that plasma inactivation, pathogen activation, was desirable. More about that in a minute. Next, please. As part of the WHO work, they developed some recommendations about the kinds of patients who could be treated when they had Ebola. The treatment was suggested that it could move quickly if there were going to be delays in making specific case definitions. If that was going to delay the use of the plasma, WHO urged move ahead promptly to use the plasma. They pointed out that at that point, the only treatment available for Ebola was supporting care or fluids and antibiotics. And the previous anecdotal experience had suggested that passive immune therapy would be more effective when given earlier in the disease. And also an advantage might be earlier in disease, lower doses might be effective as opposed to when the patient had more severe disease. And so therefore they concluded that due to the high mortality and morbidity within a week of onset of Ebola, patients should be treated as early as possible. Next, please. So this is a small study of the use of convalescent plasma in Ebola. Describes 8 patients with severe Ebola disease. 4 of these had severe hemorrhagic disease, 2 others were comatose. They received blood from Ebola survivors, 1 transfusion to each patient. You see here the volumes that patients were given, ranging from as low as 150 milliliters up to 450 milliliters. 7 of these 8 patients survived, even though they had very severe disease at the time of the transfusion. And while this was not a controlled study, the contemporary fatality rate in those care facilities was 80% at that time. So this was a pretty dramatic clinical effect from convalescent plasma to these patients. Next, please. This is another study on the different Ebola epidemic. And Dr. Geary has also already mentioned this study was published in the New England Journal. And I think, well, you can see he mentioned 514 patients. They ended up being able to analyze, if you look down the bullet points, the plasma group of 84 patients, which Dr. Geary has mentioned. And I point out here in the plasma group, 31% of those patients died, compared to 38% of patients in the control group. So Dr. Geary had read to us the narrative interpretation of the authors of this study, and it's illustrated in the last bullet point here, that while plasma resulted in 3% lower death rate, this was not statistically significant. 31% versus 38% is 3% lower death rate. So the results of this fairly large study of convalescent plasma for Ebola in Guinea were not definitively helpful and suggestive of benefit. Next, please. Another approach to thinking about the passive antibody treatment in Ebola is illustrated here by several animal studies. First, goat anti-IgG to guinea pigs proved successful in managing Ebola infection in the guinea pigs. Equine IgG to baboons was also successful if given early in infection. Polyclonal antibody from survivors of the Marburg virus given immune plasma 48 hours, day 4 and day 8 post-infection. 2 of the 3 patients had no sign of clinical disease. 1 patient had mild disease and survived. So again, what do we make of this? It's a little bit of information that is somewhat encouraging, but again, not definitive. Next, please. My next 2 or 3 slides are description of a clinical trial that I had the opportunity to be involved with in Liberia in the more recent Ebola epidemic there. And so I'm going to describe a little bit about how the clinical trial was structured in 2 or 3 slides. But I have to jump ahead, and I don't want to tantalize you with all this. I have to jump ahead and say, in the end, it took a while to get this study structured and get everything up and running. And while we enrolled some patients, which I'll tell you more about in a minute, we enrolled too few patients in order to be able to draw real conclusions. But the reason that I want to show you these slides is to make the point that I'm going to make at the end, that while it seems relatively straightforward to collect some plasma from recovered patients and give it to other patients, it's very difficult to set up a program to do this. So in this clinical trial, the plasma donors were individuals who had had Ebola within the past 2 years and survived at least 60 days. They had to survive at least 28 days from hospital discharge. They had to be test negative for Ebola by PCR on 2 occasions, at least 48 hours apart. They had to have negative tests for the usual transfusion-transmitted diseases, HIV, hepatitis B, hepatitis C, and syphilis. And you notice I put in red here, this was all done by rapid test methods. The environment in which this trial was carried out was difficult. They did not have access to the kind of ELISA testing that would often be done, and they certainly didn't have access to nucleic acid amplification testing. We did collect samples for research testing at Fort Detrick, Maryland. These were all de-identified samples, so in the end there wasn't any really reasonable way to connect the virus levels to the individual patients. Next, please. The plasma was collected by adults, recovered patients who met all the WHO donor selection criteria. They donated no more often than every 14 days. Plasma was collected by plasmapheresis, resulting in at least 650 mils of plasma from each donor. This was then separated into 6 100 ml units, and it was subject to pathogen activation using the Intercept system. The units were frozen to be used as 100 milliliter fresh frozen plasma units. The plasma was quarantined until the results of the Ebola testing in the donors confirmed that they were Ebola negative. Next slide, please. The treatment strategies were that a dose of 2 100 ml units from 2 different donors was used. And this volume was based just on anecdotal previous experience, including a single 500 milliliter dose used for influenza or Argentine hemorrhagic fever. The Rhesus Max received 480 mils of plasma, but we were also concerned about fluid volume, which might make more complications for the patients. These patients received then a second dose of 2 100 milliliter units at 48 hours. This second dose decision was based on the clinical condition of the patient. There were no fixed patient assessment criteria to use to make this decision, other than if the patient's fever and temperature decreased below 38, they did not receive the second dose. There was no clinical scoring system for use in evaluating Ebola's severity or progression. And in the second transfusion, the same 2 donors as the initial transfusions were used. A third dose of 2 100 milliliter units was given at 96 hours, but because of the complications, the sophisticated testing necessary to determine viral load, the viral loads were not known during the process of this decision making. So, as I mentioned a few minutes ago, I'd love to tell you a lot of great data. We don't have it. We were able to enroll 15 patients in this trial. This was not a randomized trial. And so it did appear that of the 15 patients, 10 of them improved after this 3 courses of therapy of the plasma. But the only thing that would be close to control that we had was the mortality at the time of similar patients in this care setting, and that was about 60%. So that it appeared in this small group that the outcome of patients who received the plasma was much better than similar patients who had been treated at the time. So I want to take my last three slides to discuss a little bit about the elements of a convalescent plasma program. Next, please. As I said a minute ago, in some ways it seems very simple. Well, let's just get some patients and collect some plasma and give it to some other patients. Well, it isn't all that simple. And I have three slides here that include what occurred to me to be all of the different sorts of things that we would like to know to carry out a really effective convalescent plasma program. First of all, we need to have established serologic assays to detect the virus in serum. Second, we need those assays to be such that we can measure the levels of virus so that we can tell, for instance, whether there is neutralization. Third, we need methods to measure antibody, and we need to understand the type of antibody that is being measured. Then we need to establish the desired level of antibody in donors that might be selected for therapeutic use. The FDA has recommended a titer of 1 to 320. I'm not an expert in this antibody testing, but if it's anything like other antibody methods, unless this is highly standardized, the titer of 1 to 320 may mean different things in different antibody assays. So it seems unlikely to me that there's very good standardization at this point. Dr. Shaz may want to mention that in a little while, I'm not sure. So then after all this, we need an infrastructure to perform these antibody titers. Some of these assays are not all that easy to do. And in a lot of these laboratories, we now have limited staff because of lone staff availability. So once we have all the antibodies, we have to be sure we have people who are properly trained to do the testing. Doesn't seem like a big issue, but it is something that has to be dealt with. Next slide. So then we need to develop an approach to screening recovered patients to identify potential donors. Do we approach everyone, or how do we decide who we're going to approach? First of all, we need to demonstrate recovery from the disease using appropriate viral, nucleic acid, and antibody screening. And the reason for this especially is some severe cases have tested positive for virus for quite a few days, even beyond the 10 days or more after the onset of symptoms. So then we need to decide what kind of donation is going to be. Are we going to ask these people to volunteer to help others as ordinary blood donors? Or are we going to pay them? All of this will need to be established. I'm curious to hear Dr. Shah's thoughts about how they dealt with this. So then we select the donors that have high antibody titers. Now we need to be sure about donor eligibility criteria to donate plasma. Is there anything about this disease that might make these people extra likely to have some kind of adverse event of plasma donation? So we need to be sure that the usual donor criteria can apply, or are there extra factors that we need to assess in order to be sure that the donation will be safe for these individuals? Next, please. So then we need to identify blood bank facilities to carry out plasmapheresis. And then there becomes the issue of, is experience with plasmapheresis necessary? One might think, oh, not a big deal, we'll just do plasmapheresis. But this is going to be done on instruments. And some of the instruments that are already used for plateletpheresis can be used for plasmapheresis, but this is different software, this is a different procedure. We need to be sure that we will have properly trained staff and facilities to carry out the plasmapheresis. Then how much plasma will we collect? Will we use existing plasma collection nomograms that are used to collect source plasma? or derivative manufacturer, or do we want to limit the amount of plasma that's collected? And do we want to make this a standard amount of plasma for each collection, or do we want to take as much as we can get? Next is what specific product will be prepared. We could separate this into units of plasma with specific volume and use it as liquid plasma, or we could freeze it and use it as FFP. It could be lyophilized or others. And so we need to determine the product size and the standardization of the plasma product that will be used. Then a dosing schedule should be established, and this could be done based on the knowledge of the SARS antibodies. And also then we want to consider establishing a registered database so that we would have access to these patient donors for future donation if that should be advisable. Well, what I've tried to do is give you an overview of the history of the use of convalescent plasma in a variety of settings, and at the end here, throw out some points that would need to be considered in the development of the plasma program. And the main point is, it's not as simple as one might think. So thank you very much.
Thank you, Dr. McCullough, for this thorough background of the literature out there on more or less recent events where convalescent plasma therapy has been used with more or less success. Also, thank you very much for pointing out all the little intricacies that go in, such as antibody titers and donor requirements. Just along those lines, now we have our next speaker, Dr. Beth Shaz from the New York Blood Center, and she's going to introduce us to the things that have been going on in the state of New York and how she has been involved in trying to set up a donor requirement program there, a donor plasma program in New York to help out with the disease. Dr. Shaz, please. Thank you.
All right, thank you very much. Thanks for inviting me. And I've seen all your wonderful questions. So in New York City, we started working with our hospitals on this probably a month ago, and we started collecting donors 2 to 3 weeks ago. We now have over 100 products collected and distributed. I cannot thank enough our wonderful hospital partners at Mount Sinai and Columbia and others. And I guess I want to start where Jeff McCullough left off, that it's somewhat encouraging and definitely not definitive. It appears to be helpful, but the literature is pretty limited. We hope in New York to have more information available. We've been working with with Sinai, who's doing a lot of testing. So, let me just kind of go through what the journey we've been on the last month. And I'm going to try and address a number of questions. So New York Blood Center started this process where under the emergency IND that came out on March 24th, we thought it was best that the hospitals recruit the donors. The hospitals could then do the negative PCR swabs, and then they could also do the antibody titers. New York State has been working on developing these assays, and as some of you may have heard, Governor Cuomo announced this yesterday in his State of New York daily address. And New York State has been a fabulous partner to us all. So one of the questions was, all of the ELISA assays currently being done by Sinai and Columbia, at least in New York State, are being validated against the neutralizing antibody studies. Now, neutralizing antibodies, those of you may know, that requires virus, and it cannot be used in a high throughput setting. So the important thing is to validate the ELISAs against that. I think I could spend an hour just talking about the antibody titers, and I know many companies and individuals are working on getting the antibody titers up and running. But let me first start with our model. So we had started with a hospital partner model where the hospitals did the PCR and the neutralizing antibody, and then the products were administered under the emergency IND by the FDA. With the FDA and ARC and Mayo Clinic announcing the expanded access protocol, and then a public way for individuals to register to donate themselves on a number of websites, which are all collated in an ABB, ARC, ABC single website. Then you as a person who has evidence of a positive test result can now go register to donate. And the way the FDA currently reads for donor eligibility, under 14 days post symptoms, meaning not a cough, not a fever, you are 100% back to normal. No signs or symptoms left. Then between 14 and 28 days after those symptoms resolve, you can then get a nasopharyngeal swab, and that would be PCR negative, and then you can come donate. After 28 days, you do not need that. We have decided at New York Blood Center that after 14 days, we are not doing the nasopharyngeal swab PCR negative. Why is this? Well, we've been talking to our infectious disease partners and many other people, and so we do not believe that that's a helpful test. As many of you know, dead virus can be living in hidden nasal hairs and other things, and it does not have clinical meaning. And also, these individuals are back to work after 7 days. So, looking at everything that the CDC and others are putting out, if they're walking down the street doing their usual activities, then we think they should be able to donate. There's not a concern for the virus being in the bloodstream, as this is not a transfusion transmitted disease, and FDA has determined it's not a relevant transfusion transmitted disease. So that's for the testing. Now, I do know that some companies are interested in doing a blood test PCR, and so I guess we'll see the results. So we have that piece of the eligibility, and then we have the antibody titers. So the FDA in their documents have not mandated the antibody titers. If you are participating in the expanded access IND through Mayo Clinic, then you save a sample, and those will eventually be sent to the NIH. You can do all the titers and hopefully correlate that to the patient outcome. We are very fortunate to have New York State as our partner, and they are helping us with these titers, and they're also helping others. This is truly a situation where we have to work collaboratively rather than competitively to get these important tests up and running and share our knowledge. Now, interesting about recruitment. I mean, in the beginning, the numbers of individuals available for donation were low. New York State had our first positive case on March 1st. So by the time you're done with symptoms and then 14 days post symptoms, it ends up being 21 to 28 days, which is okay because that's when the antibody titers start going up. And then the other issue about donation is that we are tapping into a population that are not normally blood donors. So these individuals are not formally blood donors, and so going through the donor eligibility and the process with them is important. As some of you may be aware, and I realize, I'm sorry, this is a pretty US-centric discussion, FDA changed a number of their donor eligibility criteria on Thursday, April 2nd. The key things to this changes were decreasing the HIV risk to 3 months for male sex with male, tattoos, and other behaviors and activities. They also changed the malaria deferrals to 3 months for travel instead of 12 months for travel. And they made a number of changes for the new variant CJD as well. All that can be summarized and seen on ABB or other websites. Now, I know Jeff brought up donor reactions. That has not been an issue in our experience with over 100 donors, but certainly we will see. We are currently doing plasmapheresis. We are collecting anywhere from 400 to 800 mLs by size. For an infrequent plasmapheresis donor, it is once every 28 days. FDA has allowed for medical discretion, so you can decide medically what you are comfortable with. And so we are increasing that. We're going to do 3 or 4 donations weekly, and we're going to allow up to 8 in 3 months. 8 donations within 3 months. We have a fair amount of experience. Our doctors are also the doctors for a plasmapheresis centers, so we see a lot of frequent plasma donors. Now, one of the things that we're going to ask, and we should ask, is what's going to happen with the antibody titers. One thing we do get asked a lot about is, does the donor need to be worried about us taking the plasma? And, you know, we have years and years and decades of experience that donors do very well, even under a frequent plasma program, that they are not going to be immunocompromised. There's very little data on what happens to the neutralizing antibody titers over time. And so we are also partnering with our organizations to see what happens with that. I guess you can move to the next slide as I keep going. So really, starting today, we are working on many prongs. One is that we will continue the hospital-directed collections. The other is that we're expanding to a public donation pool. And lastly, we're getting help from our public health officials who also know who's been positive, and so can help recruit donors that way. We're then booking them. Now, we have worked incredibly hard to expand our capacity using our fixed donor sites, and by moving things around we're able to then collect other products in other locations. I mean, as you may or may not know, the use of blood has dramatically decreased. I think reports are over the nation, it's about a 30% decrease. So then we can use those resources to collect convalescent plasma. And then over time, we will open it up in our other divisions throughout the country. So I think really what's very important is that we have the Mayo Clinic Expanded Access Protocol, which is really for the most severely ill, as is the emergency IND. And I cannot thank Hopkins, Columbia, and other organizations who are doing high quality randomized controlled trials. This is really the data that we need. And I think as you have seen presented, which was really important previously, that these high quality randomized controlled trials have not been available. And so most of them, I think, Eric put out that there is 4 or 5 different ones, and we have, you know, the sickest, we have the more mild, and then we even have exposure prophylaxis. So they're not, you know, the nurses on the floor, the people intubating these patients have a very high risk of getting this. And so being able to give them a prophylaxis is really important. And so I think we really need to continue to support high quality randomized controlled trials. Then I think, you know, looking at donor recruitment and what are the bottlenecks to this whole process? Well, one of them is having enough people having the diagnosis, because many of us live in locations where we have not had enough tests. So that's limiting people that were symptoms only that were not able to get tested. But the number of donors increases every day as we get further into this pandemic. And so now, at least in New York City, we have thousands of people that have all the correct documentation. Some of them also have already had their titers done. Other ones will do their titers post-collection. Then there is a group that have either been asymptomatic or mildly symptomatic that never received a definitive diagnosis. This is a group where if we could do a huge screening, then we can find them or we can test them. And there's a huge push for antibody testing on every front. And I think that this would be a future thing. You know, there is one company that has like a point of care device where you can do that screening. And I think sensitivity and specificity are really important. You want to make sure that if you're telling someone they had it, so then they feel like they can go to the grocery store or go do whatever, they're going to have a big party and be out on the streets and enjoy being immune, that we really need to make sure that they're immune. And so I think we're not quite, I don't know how much data we have on that yet. And I still think that there's been questions lingering about the length of the being immune. So when this slide is about challenges, and I think many of us working in this space have, every day we wake up to new challenges and we keep conquering them on every day. I mean, from the blood center side, you know, for the last 6 weeks, we've been changing how we collect blood and what we tell our staff, and social distancing and staffing levels, and no longer performing mobiles, gloves and masks and cleaning, and what we're telling our employees as well. It's unfortunate that we have a number of employees who have COVID-19, and so we're also addressing all of those staffing issues. So I think there was a couple points. But one of the reasons that between 14 and 28 days we've decided not to do the negative nasopharyngeal swab is, I think, from a resource perspective, I think it's very important to get people diagnosed rather than keep repeating and spend time and resources testing these individuals. So then one more thing that Jeff mentioned was pathogen inactivation, and in an ideal world, maybe we would have it. At least in the US, there's a number of challenges. There's one approved system through Cirrus, the Intercept system, and then there's a couple of systems used in Europe, Macropharma and Terumo BCT. And so part of it is just we would rather focus on getting these products out the door rather than focus on bringing up these technologies I think all of them, there's a fair amount of product loss. And so if you're talking a 10 to 20% product loss, that's 20% for every 5 doses you collect. That means you're only transfusing 4. And at this second, there's a huge amount of pressure to see if we can maximize every single unit out the door. So I think these are really different balances. However, I'm very cognizant that when you're transfusing prophylactically, your risk benefit's going to be different. And so then maybe you would look at that equation differently than when you're transfusing very critically ill or certainly severely ill individuals. Is there another slide? You know, I think we are really all trying to work together as a community. I know we have had a lot of missteps, but we keep correcting them and talking to each other to make sure that now there's going to be a single place where donors will know, okay, this is this place I should go to in my zip code to go donate. We're going to be able to leverage our incredible network of blood centers throughout the United States. BARDA, through the American Red Cross, is going to, with extra units in the system, they will then have a way of determining where the units should go that's unbiased and equitable, which I think is really important. I guess that brings up another point that going forward is once we start building a public inventory, we need to make decisions about who should get these products. And that's really tough. I think many of you saw the New England Journal paper on fair resource utilization. And ideally, it's a lottery. It's not a first come, first serve. And as a blood center, we're used to sending products out to hospitals. And then the hospitals deciding on what patients to give these products. And we've been having many discussions, both on a national and a local level around this topic. And then, you know, I think there will be a transition to hyperimmune globulin. And you may have seen the announcement that was recently put out that about 4 plasma centers, and I don't remember all of their names, are working together to get this product out the door. And I think as Jeff mentioned, the pool size, normally they work on really large pool sizes, but I think they're working to test smaller pool sizes so they can start making some products. And with that, one more thing I wanted to point out that came up on the questions is that we're making, from an FDA standpoint, the product we're making is the same as an FFP, FP24 frozen product, plasma product. So then it's frozen within 24 hours. It goes to the hospital thaws it as they would an FFP. And as an FFP, they could relabel it for 5 days. Immunoglobulins are pretty hardy, so I would think you could do longer, but I don't think that this isn't a product that you need thawed on the shelf. Another question that I thought I would just address was dosing, because this does come up a lot, and the different clinical studies have, you know, they mostly say 1 to 2 doses, and I think you have to decide that based on the patient size. And then the doses is 200 to 250 mLs. So thank you very much, and I look forward to answering your questions later.
Thank you, Dr. Shad. This up-to-date information from your experience in New York and all the challenges that come with that. Next, we are moving to Europe. We are now going to Madrid, Spain, and we will be hearing from Dr. Bueno how he has participated in developing a clinical trial protocol for Spain for convalescent plasma treatment there. Once this trial is complete, we will actually see real solid data on how to treat patients with convalescent plasma. We will have, for the future, a much better understanding how to use this treatment therapy. Thank you.
Thank you very much. It's a real pleasure to be here sharing with you. This meeting is a big honor for me to be involved in this presentation. I'm a medical doctor belonging to the Puerta de Hierro Hospital, that is a big hospital in the outskirts of Madrid. And these are the numbers of Madrid these days. We are having around 140,000 declared cases of COVID-19, more than 14,000 deaths, and regarding the number of inhabitants that we have in our city and in our county. Sorry, these are the data from the whole country in Spain, and these are from our county in Madrid. I have to say that these data are not real, in fact, because the number declared are just the people that have been that have received a test for the COVID-19, for the SARS-CoV virus, and only the deaths that are reported here belong to those cases that have been previously diagnosticated by, of the disease. So we are in the middle of a big pandemic in our city. My duty in the hospital is the head of the blood banking. As I have previously reported, but in the afternoon, my duty in this pandemic is to go to the all people institution to face the pandemic, the disease directly, treating all people that are confined in institutions. So I'm here in this meeting because we decided at the beginning of March, actually the 10th of March, to define a clinical trial to face this disease. I have to say that in 10 days, the 23rd of March, we have a ethic committee approval, and then the 2nd of April, we have already begun to recruit patients for this trial. As you can see here, this is a multi-center randomized clinical trial to use convalescent plasma versus a standard of care. So this is a one-to-one, a two arms clinical trial where we are going to treat patients with pathogen-reduced convalescent plasma plus standard of care against the control arm that is the standard of care treatment. As you can see here, there is some interims analysis, especially because, as I'm going to talk to you about later, we are more worried about the safety of this plasma more than the real efficacy that we can expect to have. As I previously mentioned, we are going to be to recruit about 20 to 25 hospitals all around Spain, and we will work between hospital, infectious disease specialists, hematologists in the blood banks, and also in the regional transfusion center that are the place where usually donors come to donate blood or the other blood components. Well, this is the primary objective, the clinical efficacy of this treatment, secondary objectives, mortality, and other ones. But we are very interested in some of the parameters that have been previously reported by my other colleagues, especially regarding the virologic efficacy and how this treatment can change the serologic conversion of this patient after the treatment. Also, as previously mentioned, also is very important to define a system to identify neutralizing antibodies. So one of the main objectives of this trial is to send all the sample from any patient that belong to this trial to a centralized microbiologist lab to perform all the tests at the same place. The primary endpoint is to evaluate the proportion of patients in the 5, 6, and 7 category. That, as you know, these are the ordinal scale to categorize patients with COVID disease. It's important for this trial that we are going to treat just patients that are not too ill. We are going to recruit patients in the scale number 3 and 4, and then we are going to evaluate how they move to worst scales. As previously mentioned, we are not going in this trial to treat patients that are already under mechanical ventilation or with a high flow oxygen or reservoir bag. Also, we will evaluate at secondary endpoints some other clinical severity factors, and also some other virologic and immunologic endpoints as the qualitative and quantitative PCR of the virus on the day 3, 5, 8, and 11 after the infusion of the plasma. Well, the main inclusion criteria are basically to recruit patients that are developing a clinical or radiologic pneumonia. That are the main criteria to include patients. We do not want patients with a more critical state. And but I have to say that these clinical criteria, main inclusion criteria, have been recently modified to this one because we have had in the first days some problems for the recruitment. So by now, we need to have a PCR positive from the patient obtained during the course of the symptomatic period of the patient, and no more than 12 days between the onset of the symptoms and the treatment administration date of the plasma. This is based on the study from Cheng that, as Dr. McCall previously mentioned, it seems that patients that in that study of the SARS-CoV-1 virus, it seems that a patient that received a treatment in the first 14 days seems to have a better evolution than those patients that received the treatment with plasma after the day 14. These are the main exclusion criteria, and regarding the selection of the plasma donor, basically we can say that we need donors that fulfill all the requirements to be a altruistic plasma donor. I mean, any criteria to be a blood donor according to the European and the Spanish regulation, and also at least 14 days after the end of the COVID symptoms, a PCR negative in the oropharyngeal swabs, and also a test that determine the presence or the positive for the antibodies for this virus. Also, and very important, we are selecting just donors that have a low risk to contain antibodies against leukocytes. As you know, because this increase the risk of the trolley problem, that is a complication, as you know, related to the infusion of all blood components, but especially to plasma. So to avoid this risk, we are selecting male donors, not transfused, and women that have not been previously pregnant, including miscarriage. And this is the plasma collection, sorry for this, and the manufacture program for the production of the plasma. We select donors that have been already recovered after a COVID disease, complying the European criteria, PCR negative in the nasopharyngeal swabs for SARS, the presence of the antibodies of this virus without symptom in the last 14 days, ideally 4 weeks from the first symptom. And this is because it seems that after 4 weeks is the peak of the titer of these antibodies, and no pregnancies or miscarriage, and also no antecedent of transfusion. When we select the donors, we perform a plasmapheresis using any machine dedicated for blood for plasma collection, and we try to collect 600 milliliters. Then we underwent that product to a pathogen inactivation system, also using any system validated for the inactivation of plasma. The more usual in Europe are, as you know, Mirasol, Intercept, or Soralen, or methylene blue. And then we can obtain 2 single units of 300 milliliters of inactivate or pathogen reduced plasma hyperimmune to be used for the patients. And well, this is basically what we are doing. We are now in the 5th day of the first, after the recruitment of the first donor. We have already infused 6 units of plasma. We have also another 8 patients that are in the control arm, and we are going slowly because we are in the safety period of the trial, and we are not allowed to include in the trial more than 3 patients in 48 hours, and this is due to a safety measure. Um, I'm going to answer or to talk about some matters of this trial and this disease. We still have a lot of doubts, not just regarding this trial, but especially regarding the disease. We are learning every day on this new disease, and we will try to answer to some obvious question that you can think about. For example, why are not we treating severely ill patients? That in other studies seems to be the first patient that are recruited for this a trial like this. And the reason is because, as you know, the patients in this disease do not are not dead due to the virus itself, but after the development of a very hyperimmune response of the patient that in fact takes to a clinical situation that is quite similar to what we know as a trial. The clinical and radiologic view of these patients is confusing with what we see when a patient is developing a TRALI after a transfusion. So we don't know if one of the theories is that problem of this patient with COVID-19 is what has been called the antibodies dependent enhancement, that is the physiopathologic mechanism that seems to take to that clinical course. So we are afraid, in fact, that we don't know if the infusion of a high amount of hyperimmune antibodies could in fact increase the risk of this problem using this hyperimmune plasma. So that is the reason why we prefer to treat a patient not severely ill, also because the study that have been previously published seems that hyperimmune plasma seems to work more effectively when we treat patients in the early stage of the disease. Also, why not using a defined immunoglobulin titer? We have seen before, FDA titer recommended is more than 1 to 320, but in fact, there are different reports on the titers that we have to use. In our opinion, we think that it is not known what is the best titer. Perhaps a high titer could increase the ADE problem, or perhaps a low titer could be ineffective. So one of the objectives of this trial is perhaps to found what is a good and real titer of immunoglobulins, specific immunoglobulin for this virus, to better identify the donors that can be selected to be used. And why a single 300 milliliter plasma transfusion? Also because if we infuse more than this and several days after the first infusion, perhaps also the risk of ADE could be higher. So we are trying to be conservatives, and also most of the trials that have been published with this disease, and especially with this SARS-CoV-1, seems that this volume could be effective to obtain clinical results. And again, why just men or women without pregnancies or miscarriage, and also without antecedent of a blood transfusion? Well, what the reason is to reduce the risk of TRALI or other problem related to the presence of antibodies, anti-leukocyte antibodies or HLA antibodies in the plasma of the donor that could affect or harm the patient that are going to receive this experimental treatment. Why we think this could be a good treatment for this disease? In fact, because by now there is not an effective anti-COVID-19 drug available, and also it is limited. We have had shortage of chloroquine and amoxicillin and several other drugs that are being used for the treatment of this pandemic. Also tocilizumab. This treatment, especially this last one, that, as you know, is an inhibitor of the interleukin-6, is really expensive, and we think that in this pandemic situation, a lot of countries are not going to be prepared to face this disease using very expensive drugs. Also because we think that this plasma, only if it is proved effective, could be cheap and could be also available in these countries, and more available when more patients recovered. So perhaps at the beginning of the pandemic or the epidemic in the countries, this is not a good approach. But I think that at this time, new countries or places where the incidence of this disease increase could be benefit by the use of plasma coming from other places where the prevalence of donors with the COVID and with the presence of immunoglobulins already could be a good source to treat these patients in new areas, and also in new waves of this disease, perhaps at the end of the year or next year. This is also because we think that a real active, effective vaccine will not be available in the next year, in the next 10, 12 months, and the same for the production and the validation of hyperimmune anti-SARS-CoV-2 immunoglobulins as some companies in the plasma industry are now focused to develop. And finally, why a clinical trial when a lot of people are dying? And that is the situation now in Madrid and also in Spain. We have a lot of pressure by the clinicians to use plasma for any people who is in a very bad situation. But we, in fact, prefer to treat patients in a clinical trial because we, in fact, are not sure that this is going to be effective for the treatment, and we are very aware and afraid also a bit if the treatment, especially if we use it in very ill patients, could also increase the risk of ADE and perhaps, in fact, increase the mortality of these patients. And why other countries are already using it and we do not? Well, but the answer is the same. And basically, I could summarize our feeling now and at this time where this disease, this pandemic is going down at end in our city and in our country. We are at this time, we are not yet sure that this is going to be safe and if it's going to work in our patient. We have to wait and see and analyze the results of these trials. We know that there are a lot of trials around the world on the same way, and I think in a couple of months perhaps we are going to have results to be sure if this treatment is effective and especially if it's safe. This is the team that is involved in this trial. There are internal medicine doctors, specialists in infectious disease, hematologists, pharmacologists, pneumologists, and a big team of statistics and people involved in the safety monitoring board. Thank you very much for your invitation, and I'm open to questions. Thank you.
Thank you very much, Dr. Bueno, for your review of your clinical trial. I'll look forward to getting real solid data from you, from your clinical trial, which will then help us in the future to treat diseases like COVID-19 or other diseases that may show up at the horizon. So we're now moving into the question and answer session here. And again, if you would like to pose any questions, use the Q&A function.